whatever happens with one population can happen with another population. And how we can just like heal together, which is really what this amazing conversation about today is. How do we heal together? But before I kick us off, I want to mention how you can interact with us and the panelists over the next like 50 minutes. And if you want to, how you want to share some stuff on social media as well. So first, we're using the hashtag MVP Connection. And then secondly, if you have any questions on the right-hand side of the chat, you'll find me. And you can shoot me questions either via Zoom, or you can also find us on Twitter at vetsandplayers or just at vetsandplayers. And we have our marketing guy, AJ, who is monitoring that for any questions that you might have. So we're going to kick it off now. And before we get started, I just want folks to get to know some of our panelists. And so first, I'll start with me. I am the moderator. I'm Jacob Toups. I'm the executive director of MVP, based here in Los Angeles. And a quick, like, 2 sentences about what MVP is. At the very basic level, it's a support program founded by Jay Glazier and Nate Boyer for military veterans and former elite athletes in LA, Vegas, Chicago, New York, and Atlanta. And we utilize the combination of physical activity and social connection to make members feel like part of a team again. And our mission is to match up both of these populations and give them a new team to tackle transition together. And so really, you know, we're facing a lot during COVID-19, which I'm excited to talk about sort of a little bit later on, and the work that MVP does in making sure that our population feels supported. And now I just want to kick it off to our 2 panelists. And so Kacie, could you do a little bit of an introduction of yourself, the amazing work that you do at the Bush Institute, and then we'll jump into Marshall.
Sure. Great. Jacob, thank you so much for inviting me. I am delighted to be here with you, Marshall, and all the faces on the screen to share some insights from my view on this, what is the 10th anniversary of PTSD Awareness Day tomorrow. My name is Kacie Kelly. I'm the Deputy Director of the Military Service Initiative at the George W. Bush Institute, where I lead all of our health and well-being work. For those of you who may not be aware, at the Bush Institute, we engage communities in the United States and around the globe to develop leaders, advance policy, and take action. President Bush likes to say that he didn't just want a think tank, he wanted a do tank, and that could not be more present than in our Military Service Initiative. Our MSI, as we call it, Military Service Initiative team, advances work aimed at fostering successful transition for military families as they're transitioning civilian life, with a focus on post 9/11 veteran families. And we emphasize, all of our work really has an emphasis on economic opportunity as well as health and well-being. And our health and well-being program is fairly new. I've been there about 3 years. But it was built upon a much more many years of the President and Mrs. Bush's work with our own Team 43 program, many of whom were featured in the book Portraits of Courage, if you haven't seen it. We know that with the right supports, military families desire to and will continue to lead and serve in our communities around the country, even after they've taken off the uniform. And so everything we do is sort of with that lens as well.
Thanks, Kacie, so much. And so we'll jump now to Marshall. And Marshall, tell us a little bit about you and your work at the Bob Woodruff Foundation.
Absolutely. Thanks so much, Jacob. It's great to be here with you and with Kacie and with everyone who's joined today. As Jacob said, I'm Marshall Lauck. I'm the Chief Growth and Marketing Officer for the Bob Woodruff Foundation. And our mission is to support not just veterans, but their families and caregivers. As Kacie mentioned, the importance of the military family. We've been very fortunate to help find, fund, and shape some of the most innovative programs that help that group deal with the current and emerging issues facing the veteran population. So we've been really proud to do that work ever since our founder, Bob Woodruff, was badly wounded while embedded with U.S. forces. And his wife, Lee, and their family became full-time caregivers essentially overnight. So it's great to be with everyone. We've been really proud to partner with MVP, one of the best-in-class organizations that we work with through our partnership with the NFL. And I'm also a proud Marine veteran. And I've had the chance to experience MVP's great platform firsthand in Atlanta, where I'm based. getting worked over on the mats and then getting some good time to spend with other great veterans and athletes. So great to be here with you, Jacob and Kacie.
Thanks, Marshall, so much. So we'll jump straight in and we're going to talk a little bit about Kacie's work and the things that she does at the Bush Institute, and we'll work into Marshall, and we'll have plenty of time for Q&A. I know a few folks were eagerly excited and already submitted me some questions, which I'm excited to get to later. So Kacie, I want to start with you and your work around trauma at the Bush Institute, and especially around the Veterans Administration, because that's where you started, right? And so can you tell us a little bit about your journey and how that journey brought you to the Bush Institute?
Yeah, thank you, Jacob. So I spent 15 years in the VA prior to joining the Bush Institute to stand up this program about 3 years ago. I started out in research and pretty quickly realized that while I completely value research and data as a part of every conversation I have almost, I really didn't enjoy research. And so I quickly moved into a role where at the National Center for PTSD in Boston, where I was part of a team that helped to advance research into practice. So once we knew that we had some good data that certain things work better than others to treat PTSD for veterans, we began to really work with the 150 healthcare system to disseminate those and train our clinicians and work with the infrastructure so that the clinicians could actually deliver these best-in-class treatments. And then I spent 9 years in DC, which was a whole nother world.
Oh, let's see if we can get Kacie to come back. Technology issues.
You know, my VA career culminated in a role where I was able to lead the establishment of a public-private partnership priority, where I was the national lead for partnerships in suicide prevention and mental health. Many people may not realize that only about 40% of veterans actually receive their health care in the VA. And so creating this public-private partnership program as a priority was really essential to positioning the department, better positioning them to be able to fulfill their mission of caring for all those who have borne the battle in defense of our nation's values, along with their survivors. So then about 3 years ago, the Bush Institute called and asked me if I would come over and help them, and just really excited to have been part of a great team over there for the past 3 years, doing some innovative work.
Great, thanks so much, Kacie. And so what are you working on right now at the Bush Institute, and what do you find most exciting and innovative? And I think, you know, it's so interesting because right now we're obviously in COVID-19. I think your plans probably for 2020 might have changed a little bit. So tell us a little bit about, you know, what you're working on and what do you find most exciting?
Sure, thank you. So I'm actually really excited about the momentum that we're seeing right now with an alliance that we have established. And some of the activities, probably not would have chosen to launch them in the middle of a pandemic, but we felt like it was important, and that, you know, more than ever, we needed to really continue to do the work. So my team has been awesome. It was easier than ever getting all of our work to the finish line. So let me share a little bit about this alliance. I truly am honored to be part of a team that has united at this point what is 15 organizations and over 50 of the biggest brain expert leaders around a single mission, which is to connect more veterans to effective care for the invisible wounds when they need it. In addition to the meaningful collaboration that we're advancing, you know, I say, like, beyond the leg, put our logo on the slide and let's all say we're collaborating. Like, these folks are actually doing some really hard work and making some hard decisions about how to collaborate so that the resources are more effective and more efficient. So what is unique about this alliance, so in addition to the meaningful collaboration, is that about half of it is made up of peer-to-peer veteran networks, such as the Mission Continues, Rubicon, the Tasmanian Foundation, while the other half are our group of best-in-class, high-quality clinical care programs for PTSD, for traumatic brain injury, for depression. what I love about this work is that everything we do positions our customer, personal 11 veteran families, at the table with equal voices. And it's really helping us to build veteran-centric solutions from a customer perspective. And while we know that effective treatments are available for PTSD, we also know that many veterans are not accessing them. And so our alliance is focused on 3 big barriers to care and have been working towards solutions for those over the past 2 years. One barrier is the negative perception and stigma that we all are aware of related to asking for help for mental health care and even talking about mental health care. The second is challenges related to navigation. So when someone is, raising their hand and wants to
Kacie, I really want to hear you because I think that everything you have to say is so important. The audio is a little bit broken.
Do you want me to call in?
That'd be great. And I'll move to Marshall because everything you're saying right now, I want to make sure everyone has the opportunity to hear it.
Perfect.
Right, we'll
Technology is great when it works.
Thanks so much, Kacie. Marshall, I'll jump into you, and your current work at the Bob Woodruff Foundation puts you on the front lines of mental health and veterans. And the foundation just released its report on COVID-19 and the impact that it has on the veteran population. And I would love to start off with like what you're seeing on the funding side, right? And so if folks don't know, the Bob Woodruff Foundation is one of the and I went through very few, but one of the leaders in providing funding for mental health. And so they're constantly in the space about raising the awareness of why in America do we need to be funding nonprofits who are supporting our populations around mental health, particularly around adults. Like there's a lot of really great work around funding for young kids and social emotional health, but we're not even talking about social emotional health for adults who, all adults are just taller children. And so Marshall, tell us a little bit about, your work at the foundation and what you're seeing on the front lines right now with the funding side.
Yeah, absolutely. Thanks, Jacob. As you noted, we're, as an organization, we make grants to a host of the best-in-class nonprofits that are out there tackling these issues on a daily basis. And COVID certainly changed the dynamic this year in a lot of ways. So while we are already investing in mental health through a number of platforms, the challenge that we faced and what we talked about in the paper we released recently, implications of COVID for the veteran community, was really about how did this dynamic change what we were doing or what the need was out there in the mental health space. One of the things we identified as a funder is the resources to support mental health were inconsistent across the country. You have some areas of really great programs, wide-ranging access. In other cases, you don't. And that was a problem before COVID. So when you think about the impact COVID had on the ability for veterans to get good mental health care and mental health resources, you could see that if it was inconsistent before, it was going to be even more strained or problematic afterwards. The other thing that we found, as a funder was really the idea that we felt like we were going to see an influx of greater need as you saw what we got to term the potential for a perfect storm of mental health issues. So if you were facing a mental health challenge previously, and now you layer that on with potentially unemployment or financial uncertainty, or as you noted early on, a return to social isolation, which is highly problematic for a lot of folks dealing with mental health issues, you're going to see those things significantly amplified or exacerbated by the COVID situation. So, what we saw was really a combination, or I would say 2 things. One, we saw some existing infrastructure that was really struggling to continue operating, whether it was based on budget or access, whatever it may be. That was one challenge, just keeping the lights on, trying to maintain support. The other thing we saw as a funder and where we really pushed some of our attention was the groups that were really quickly adapting their model. So trying to move smartly and quickly to a way to maintain services for the veterans who really need it. I mean, the obvious example was going to virtual or telehealth. It's obvious, but it's not always easy. It's not as simple as it sounds. So the ability, to pivot both as a funder and to look at those organizations already pivoting, could we help them maintain or transition those services so that you could provide them to the veterans and their families who need them at a time when arguably they probably need them more than they ever have.
Yeah, that's so important, Marshall. And I think we talk a little bit about, about like adapting right now, and how adapting is so important just to serve the population. And there's so many amazing organizations out there right now who are still learning to adapt their services. Unfortunately, some are not able to continue, and some are continuing their services. And so now it's becoming a critical time that people who can pivot, that they are able to continue providing those services. And, a little bit about just like what you said around the gaps in mental health services. And I know that Kacie will talk a little bit about this too, is if anyone has seen like the Patriot Act, which is a series on Netflix by the comedian Hassan. He did a whole piece on mental health about a month and a half ago. And what's so startling is that in America, there are places where the nearest therapist is 6 hours away, and there's only one in a 6-hour radius. And so what we're talking about, which Kacie and I have had extensive conversations of, is like, we talk about the VA system, where we talk about if you're with the NFL, you get about 10 sessions. If you come out of the NFL, a lot of preconditions there, in our population specifically. But, what does it look like for an average American to be able to just access mental health services? And what we're finding is that, like, it's really challenging. It's either distance, or if anyone's ever tried to go through their health insurance to try to get a mental health provider or get in touch with someone, good luck. It's very hard. It's very, very, very hard. And so we're not prioritizing this. And what's really exciting about the work that Bob Woodruff funding and Marshall is that it's going to be able to show some of these best practices, the whys. And my hope is that we show, hey, like, for this small slice of population, it's working. We're doing really great work here. And how can we transform the whole system around mental health in America based on some of these really amazing best practices? But it has to start with someone going out on a limb and funding some of these organizations who are piloting innovative ways to grow on the mental health side. So with that, I do want to jump in, Marshall, to where you're seeing innovation and where you're seeing gaps. Like, obviously, we're seeing some innovation here on the telehealth side, and then we're also still seeing gaps, as I talked about the distance challenges as well. And so, from your perspective, what's going on innovation and what's going on in gaps?
Yeah, definitely, Jacob. And I think you hit on one of the most important aspects of innovation. Is I've often found that typically people think of innovation as synonymous with technology. And certainly there is much that technology can do that's innovative. Like the shift to telehealth or virtual is an innovative way to deliver something that otherwise had historically been face-to-face or in person. I think another facet of innovation we've really looked at is that notion of expanding the network or creating more infrastructure, as it were. Like, how do we grow that network? So, if we can increase the size of it, both, geographically, like extending out into remote or rural areas, or even as fundamental as increasing the size of the network of trained clinicians. So one of our grants, for example, is with a group called Strong Star down in Texas. And the focus of the grant is twofold. Like, first, it's to train clinicians in evidence-based care, which we know is so important to this. And then second, we've done things like create a stipend program to ensure that we can bring the clinicians in for the training or pivot to a remote training program. And so we see sorry to borrow from the vernacular, but a force multiplier in that we've got a larger network of trained clinicians who are not only treating veterans now, but have the training to do it going forward. So we're trying to innovate in that sense and push out the connections and the capabilities. I think the other thing is, and I think you all and what Kacie's work is doing is another aspect of innovation, and it's overcoming that barrier around the stigma of asking for help. I mean, I worked on the distress hotline for the Marine Corps probably 15 years ago, and General Amos said the same thing at the time. I want to destigmatize the act of asking for help. When I hear your founders talk about it in the small circle, they're like, it's not about you, it's about your buddy. Check on them, make sure they're okay, and let them know that it's all right to ask for help. Those are a couple of the innovations. Real quickly on the gap front, and I think it's a bit of what Warrior Wellness Alliance is doing. Some of the gaps are just around collaboration or around bringing organizations together having them do what they do best as an organization, and then partner where there's an area that's not their skill set or core competency. And whether that gap's there just because everybody's very mission focused, or it's just taken a catalyst like, the Bush Institute to do it, I think the more we can get the groups together, working closely, collaborating, I think that's a gap filler that we can all benefit from.
Yeah, I think about that, Marshall. Lately we talked a little bit about the sort of collapse in services here in Los Angeles, particularly around COVID-19, right? And so, for the audience, prior to this, like Kacie and I and Marshall were talking about, in LA, we have this amazing council called the Mayor's Suicide Prevention Council for Veterans. And, as COVID-19 was happening, unfortunately, the collaboration that we had in place earlier was strained. And that's just because, people are doing, when you're working for the mayor's office and the county, suddenly everyone's raising the alarm about their own population. And so there's this sort of like disbursement of collaboration because everyone's trying to put fires out, and we become a little bit less proactive and a lot more reactive. But in those gaps, what happens when there isn't collaboration is mass confusion on what services are still out there. I still have people in my program I need to refer to. Are those people still at the VA? Are those people still at these places? Like, what's happening here? And I think that we're learning a lot of really interesting things about what happens when collaboration isn't in place. What I'm really excited about is the folks that we've worked with in Atlanta with their Warrior Alliance is like, they're doing some amazing work out there on some collaboration, right? And we're literally tracking, or they're tracking, people going from one site or one nonprofit and receiving their services to the next one, and how important that is, so that we understand that one organization provides a really great service, and then the next organization provides another really great service, and that you do it really well. And Marshall said something so important about evidence-based, like research-backed program models. And this is where we're going. And when we first got connected to Bob Woodruff, we talked to Meg, and Meg loves her logic models. And I came from the AmeriCorps world in my last and previous job. And we joke that, some of these like program models for nonprofits are, all theoretical and change of theory and, but it keeps you on this business plan kind of thing for your program. And I think that, folks like Bob Woodruff, and we'll get back to Kacie here in a second, but the work that Kacie is doing around evidence-based approaches, it makes sure that when you're working with a nonprofit, that you're holding yourself accountable, and other people are too, to those best practices. Because if we're not doing the work with best practices, then we're not actually doing high quality work for the people that we serve. And that's really where we want to get to, is how do we get to high quality services for the folks, knowing that they may not be receiving that in other places in their lives, but when they show up to your program or what you're doing, you want to make sure that you're holding yourself accountable to high quality services. So thanks so much, Marshall. I appreciate you. We'll come back to some more questions that we have for you later. And I do want to go back to Kacie, because Kacie was talking about some amazing things with the Warrior Wellness Alliance. There's so many alliance wellness, but we talk a lot about research evidence stuff, and this is a great plug for you, Kacie. So please bring us back to your conversation on the alliance that you've worked on. Oh,
you guys can hear me?
Yep. Little echoey.
Yes.
No, nope. Let's see, Kacie.
So for some reason, I'm coming up as Steve Jelks.
I know. Okay, but we can hear
Okay.
you now. Yeah.
Okay, great. All right. Hopefully it will hold. Technology is beautiful when it works. So I love that you guys are talking about evidence-based care for PTSD and for mental health broadly. That sort of squarely fits within one of the barriers to care that we were trying to address. That even though that we, through this alliance, know that effective treatments exist, veterans were not finding them. And so how can we, through our alliance, when someone raises their hand and sort of overcomes that negative perception and stigma, be able to navigate to high quality care? And while we know and then at the same time, we know that there's limited quality mental health care in the country. We also know that treatments do work and that people do not have to live with PTSD for all of their lives, and they can get better. And so we're getting ready to roll out a number of products that we have been working on over the past 2 years that are aimed at addressing the negative perception and the stigma piece, aimed at addressing the navigation piece, as well as something I'm really excited to share with you guys about the limited quality, how we're going to address the limited quality care. So one example that I can share with you today is that when working with our peer networks, we have learned that even though our peer networks do not have mental health care delivery as their primary mission, they have a role to play, and they want to play a role in the continuum. They help to foster in their programs thriving veteran communities that establish such an important, what we call the circle of trust. And, you know, through their physical fitness activities, through their civic engagement, through the community aspect that they're driving, they also, as a byproduct, establish trust with their peers. And that is such a critical piece to helping reduce stigma and to encourage someone to reach out for help when they're dealing with perhaps some more serious mental health challenges. And I think MVP sees that in the programs that they're running. And so we've operationalized a role for these veteran peer leaders, and we're currently testing that process for peers to be able to check in with their buddies in 3 veteran markets, where we're hoping we will refine whatever process, you know, the process that we have put together, and be able to share that new knowledge with others so that we can really put people to work. My perspective is everyone has a role to play in fostering thriving communities and fostering mental health, not just, you know, mental disease, you know, preventing disease. And I also believe that everyone has a role to play, and everyone can play a role in that.
Thanks, Kacie. Thanks so much. And you know what, Kacie and I talk about specifically about this alliance that's really exciting is the fact that some of them are non-traditional ways of healing. But, you know, in the last 5 or 6 years, it's been, we've just seen an explosion in brain research, right? We're talking about how simply physical activity, these things that are basic things we think about, but we don't think about them in the healing sense, can actually help, right? And so it's things around post-traumatic growth. And that's something that's really exciting to talk about now, is this idea that people can grow from PTSD. There is a way to move along the continuum. And sometimes people, and we do recognize this in VP, sometimes people do actually need medication for the stuff that they're going through. Other times it's simply just like diet and exercise and connections with people, and how social connections just with one another is so vital. And there's been great studies in showing that, you know, connections with your peers lowers depression, it lowers anxiety. And so we're seeing some of this amazing research. And it really, and I think a lot of people are saying, well, why didn't we know that 10 years ago? Well, no one was studying it. They thought that it was really some basic things that were happening. And they didn't really connect the 2 dots together. And so the work that Kacie is doing is she's trying to cultivate all of these, this amazing evidence, because what happens here is then it can get funneled up like we talked about. And we really want to see together, as we're sort of united, you know, how some of these best practices can talk about the higher levels of mental health in America. And I think that's the next step in where we go on PTSD awareness and mental health awareness, is we go to this place where we're now currently siloed in refugees with mental health challenges in America. We're siloed in, you know, veterans, we're siloed in all of our different populations that we're working in. And where we need to go next is what Marcia's talking about, which is collaboration, right? What are we learning from each of these disciplines, and how can we cross-share? And one thing I was excited about when I came to MVP is talking about trauma-informed care. And it's a very basic concept that you can take high-level psychology principles that you'd usually need to go 4 years or more to get a psychology degree or a social work degree, and boil them down to being trained, and how nonprofit program managers should be trained in some of this content. And I think that, you know, what's missing in the gap space in the nonprofit space for Los Angeles, or not for Los Angeles, but in the nation around mental health, is simply training. Who is out there training? And, you know, Kacie and I and Marshall talked about some great suicide prevention training that's out there, some suicide intervention training. And sometimes those are so narrowed, because when we think about going into those training elements, we're looking directly at what's happening in the moment, but we really want to move from intervention to prevention, right? Like, how do we talk about the people and how do we get to the people before they fall into this intervention crisis line that Marshall's talking about, right? And we keep hearing over COVID-19 over the last couple of months, Sundays are the busiest days for the crisis lines, and they are off the charts right now. People are calling in, and we're not talking about just the veterans crisis line. We're talking about every crisis line. People are calling into these mental health challenges. And so, you know, as we think about this, I think what I'm really excited about with some of the questions that are coming up and with having Kacie and Marshall on here is that there's actually practices that we can access in our home space, right? That Kacie's learning from the Alliance, that Marshall's learning from the people he's funding, because right now the healing can start today. And it's really our responsibility to figure out who we can connect with to help us sort of hold ourselves accountable to some of these new practices. So with that, I'm going to jump into questions, some Q&As. And I've got one question, which is anyone tracking results or how many veterans are receiving assistance? And then, you know, number two is if they are tracking results or how many veterans are receiving assistance, which I know Marshall and Kacie can talk about, are there any measures of effectiveness? So Kacie or Marshall, who would like to take that?
I can start, and then Jacob, I'm sure you and Marshall can chime in. So the question, I think, what kind of assistance? If we're talking specifically about PTSD, which I think we are, yes, there are lots of. There's actually the past 10 years have really been just such a catapulting few years as far as what we didn't know and what we do know now about PTSD and treatment outcomes. And so within VA, there are all sorts of measures that track treatment effectiveness, as well as patient satisfaction. One of the things that we're really advocating for is that those same levels of quality and outcomes are being tracked outside of the federal government. Federal government has to do it because Congress makes them. In the private sector, there really isn't a lot of accountability and enforcement. And so one of the things that we've done as the Alliance that we'll be releasing in the next few months is actually establish a common definition for what quality care for PTSD and traumatic brain injury looks like, as a bar sort of beyond the research that tells us what treatments are actually more effective than other. Like, this is something that really we can hold healthcare systems accountable for, nonprofits accountable for, and something that consumers can actually use and demand and expect. That said, someone brilliant once said to me that the state of mental health and brain health today relative to what we know about other healthcare challenges is really comparable to an AM radio compared to like Spotify and Pandora, right? So we have a lot of opportunity in mental health care right now, but I think what I'm seeing is just increased attention and acknowledgement that mental health is health and that people can actually get better. And it's not always a medication choice. It can be talk therapy, it can be peer support. And so the good news is that there is innovation happening across all disciplines to advance both those biological solutions and those talk therapy solutions, and also public health solutions. I think my call to action on this topic is that we just need much more collaboration and coordination related to data and research so that we can help more. And there are so many things that we can be doing outside of the healthcare setting that I really am trying to advance in my perch right now. Like, what are the ways that everyone can play a role in addressing and promoting and fostering thriving as part of a prevention model that Jacob referred to.
Yeah, I love that, Kacie, because, you know, we're talking about just like, how do you, I think the challenge in the mental health space that Kacie is referring to, that we're trying to build some structure around, is how do you measure social emotional health? How do you measure someone's confidence levels? How do you measure some resiliency? And the last work that I was doing with kids, we were really trying to figure out, how do we pin this? And, you know, to say like the youth development space is really advanced. I mean, they have jumped like and done some amazing things, leaps and bounds, and they're still trying to figure it out. And so we're talking about how do we measure these like emotional health types of things. it's really hard to measure, and I know that we'll get there. And there's been some amazing work by the Wounded Warrior Project and the folks over there on some like data and research and surveys they're rolling out most recently. But really simply, like what Kacie said, right, is that we just need more data, and we need to figure out and kind of go from this. We'll first collect, then, you know, come down and narrow, so we can really figure out what measures of effectiveness are out there that we really want to, you know, pin down and really hold ourselves accountable to. So I'm going to move to Marshall now. So Marshall, anything around effectiveness that you're seeing in the mental health space?
Yeah, absolutely, Jacob. And just, I think to build on what Kacie was noting about the notion of accountability and measuring things, you know, I would say I'd probably speak less to the idea of measures of effectiveness around the treatment methods themselves. And from our point of view, we feel like a very strong responsibility if we're granting to organizations doing evidence-based care that we're measuring or holding them accountable for ensuring that care is delivered. So we know that they're doing evidence-based care, that as Kacie noted, you can, and you noted, Jacob, you can heal from this with the right type of treatment, that we ensure that the grant we have out there is training the appropriate number of clinicians, ensuring we get the broad coverage that we expect in the veteran community. And also, you know, many of the same organizations that are part of, you know, Warrior Wellness Alliance from a collaborative standpoint are also grantees of ours. So we're looking to focus our efforts there on the group-based or peer-to-peer or fitness-based activities that we can then measure the level of coverage we get. That's very important to us. I'd also just note that, and I think you said this earlier about the silos we may find ourselves in. We're talking about mental health and PTSD. I mean, these are people problems. These aren't exclusive to the veteran community. And if we're disproportionately predisposed to them based on the impact of service, it's maybe less of a badge of honor and more that call to action that Kacie's talking about of how can we collaborate, how can we share outside of our space, and how can we learn from outside of our own little cohort to advance what we're doing here, and then, you know, extend that to more of the vets who need it.
Yeah, thanks so much, Marshall.
Yeah, Jacob, I'd just like to say one other thing on this bit, because I just feel like I'd be remiss if I didn't address the fact that, as you noted, I think when you kicked us off today, that mental health doesn't discriminate and it impacts all communities. And we know that PTSD, depression, and anxiety are treatable. And we also know that racial minorities are more likely than whites to have PTSD. And while we know that these effective treatments work for many, they do not work for all. And so we have a lot of work to do to understand how we more precisely match the right treatments with the right people so that we can serve more better. And, you know, I want to encourage funders and policymakers to really begin to prioritize this challenge. We have to stop thinking about this as a one size fits all, and as consumers, as a like, once I go seek evidence-based treatment and it doesn't work for me, that doesn't mean that there isn't something else that can work for me. It's like going in for, you know, a cancer treatment and only thinking that there's plan A, when really there's probably plan B, plan C, plan D. What is my alphabet? So, you know, I've also been working with the Alliance to figure out how we better understand our customers in more of a subpopulation and a segmentation way, because we know even within the veteran community, there's a wide range of subpopulations. And I think, you know, through research and some innovative data projects, we can better understand the new neighborhoods that we need to understand how to outreach to, as well as treat, and help people navigate to those quality resources in their language and in their culture. And I just think there's a lot of work we still need to do there.
Yeah, that's so important, Kacie. And, you know, I think that you hit it on the head about just like minorities, like being more predisposed to, you know, traumatic events. And this is stuff that Nadine Burke, who's the California attorney or Surgeon General, she released this back, like 6 years ago, adverse childhood experiences. And these are just like traumatic experiences people across the US experience as kids, right? That research was done in the 90s by Kaiser Permanente. And I don't know who sat on that research for over 15 years And then someone said, hey, maybe this is actually relevant to what's actually happening. And the ironic part about Kaiser Permanente, releasing a lot of that was that they were trying to do research to obviously make sure that their healthcare model was on the preventative side. And so it's so interesting that sometimes we do the work and we do the research and it sits on it. But what's become of that and the explosion of just understanding on a scale, and we talk about measures of effectiveness, right? And the A scale, if people don't know, adverse childhood experiences scores are from 1 to 10. And as time goes on, as you experience these things, you ratchet up 1, 2, 3. And like I had said earlier, most Americans have at least one adverse childhood experience. But as you sort of add to this pyramid, it actually affects your overall mental health, right? And not only that, but just mental health and also physical health. And the alarming part is that we're seeing it disproportionately in some of our underserved communities. And that is a hard pill for us to all swallow. So the challenging part about when we're talking about mental health is that it's complicated. And Marshall and Kacie and I talked about, we're measuring effectiveness maybe in kids, right? So the kid goes to the doctor, you bring your kids to the doctor and they get a score and they ask a series of questions and you get a bunch of questions about, emotional stuff that's happening at home, et cetera, and maybe your kid does get a score, right? But because that research only came out 6 years ago, and Nadine is maybe one of the few people doing it with some of the doctors in California, it means it's not even widespread yet. So we're not even seeing this sort of outlayered effects of some of these measurements. And so our challenge now is that we're talking about, what do we do with the adults who never got these scores? How do we manage the folks and really get the care to the people who never experienced some of this stuff, but definitely childhood trauma has experienced for quite some time. And how do we get people to understand that sometimes in life things happen to you, and how do we get to a place where we can heal from that? And so I think that, with effectiveness, we're learning a lot. And we just want to make sure, as we're talking to policymakers and other folks, that it's like, of course, we're addressing based on the research that we sat on for over 20 years, that we're really looking at kids and trauma right now, but we also need to look at adults with trauma, because those people are in high profile positions across the US, either they're in leadership roles or they're in other kinds of spaces. They're also experiencing the same things. And you can only imagine going to one of these tests, these adverse childhood experiences tests with your kid, to find out that they have some sort of childhood trauma, and it makes you reflect back on, maybe I also had that. So it's kind of systemic sort of waves that we're talking about here. And so, I love this idea, Kacie, that you brought up, that it is disproportionate. And I think that is something we really need to talk about. And then, what happens when those people go on to do other things in their lives, and it sort of compounds a bit. So thanks so much, Kacie, for bringing that up. I do want to say there is a comment on the side, and I would love Kacie to talk a little bit about this too. And Marshall may know about the UCLA's Operation MEND program. And so if you're not aware, the Operation MEND program is a part of the alliance that Kacie's working with. It's in Los Angeles. And so I've had the opportunity to meet with some of those folks over there, and they're doing some amazing work. And so Kacie, I know that you know the folks over there. Can you tell us a little bit about Operation MEND and the work they're doing?
Okay, the host had muted me. So OpMen, I'm a huge fan of OpMen. There are actually 4 similar programs to OpMen around the country. One's at Emory, one's at home base at Mass General in Boston, and one's in Chicago through the Rush Road Home Program. And what they have learned is that, so these evidence-based treatments for PTSD that we've all been talking about primarily involve, or what we know the most about, cognitive processing therapy or prolonged exposure therapy, which are both cognitive behavioral therapies, talk therapies that last anywhere from 9 weeks to 12 weeks in an hour to 90-minute weekly sessions. And they sort of help the consumer go back and really process those traumatic events and identify what are perhaps more healthy ways of coping with them. All of us, when we experience a trauma, we just want to stuff it and we want to put it away and pretend like it didn't happen. Over time, that doesn't work so well. And we end up developing all these unhealthy ways of trying to keep it stuffed and ignoring it. So what what these treatments do are sort of help you to go back and then relearn a lot of the way you think about that trauma and a lot of the behaviors and emotions associated with that trauma that developed. And they've had great success with the veteran community, with the sexual violence community. And what these 4 programs have done is basically condense those treatments down into 2 to 3 week programs. And you not only have the weekly sessions, the 1 hour, 9 to 12 sessions, you also have all the wraparound supportive treatments, whether that's yoga, whether that's anger management, whether that's physical fitness work. And so you just get a really high dose of therapy over the course of a 2-week period. And you don't sleep at the place. They actually put you up in a hotel room, usually connected or across the street. And they even fly you to the destination along with one of your family members or caregivers to participate in some of the therapy. The outcomes for this work has been phenomenal. It has been phenomenal both from a treatment outcome perspective, but even probably more exciting is that in those traditional outpatient programs, the weekly sessions, we see a lot of dropout. In fact, only about 40% of veterans complete those treatments. Whereas in these 2-week intensive outpatient programs, where really your job for 2 weeks is to focus on your PTSD and your TBI, the completion rates are up more towards 95%. And so we're really excited to see this as a model. VA is looking at it as a model. And what has happened in sort of the world of COVID is they've been testing out how to do these 2-week intensive programs virtually. And we're seeing, again, some really exciting preliminary data. And so that to me is super exciting from a systems perspective, because that opens up so much more capacity for how many people we can see and how many people can actually benefit and get access to these programs. Because if we can run them virtually, that just alleviates all sorts of the operational costs and burden associated with it.
Yeah, I think COVID, Kacie, has proven to be, it's a really challenging time, but it also shows us some really interesting innovation. Although, like you had mentioned in the beginning, right? Like that if we have like a pillar of technology, and Marshall mentioned like that, it's not just like one thing, but technology, in-person care, like all of these options is great. But I think the fear of telehealth or teletherapy prior to was the effectiveness of it. And now we've been sort of forced to try this model out, and we're learning some really interesting best practices around that. I do want to ask, Marshall, on the Bob Woodruff, research study, you guys had released a couple months ago. Tell us a little bit more about that, if you could, for a few minutes, and why that was so important for the Bob Woodruff Foundation to fund that and to bring that research forward.
Yeah, absolutely. It was really getting that paper out the door was really our opportunity to help. And we also felt like our responsibility to share some of the data we collected. The report's built off of a platform, that we call our local partner self-assessment tool. And it's essentially a data survey tool that we use throughout our local partner network around the country. So we currently manage, through our National Veterans Intermediary Initiative, this network of just over 100 local partner collaboratives in over 45 states. And those collaboratives collectively represent about 3,000 plus organizations serving veterans at the local level around the country. So we pulled the data together in terms of how the local partners are able to support veterans. So what services are available, and then what services are meeting veteran needs at that level. So matching the need to the service. And with the arrival of COVID, we're able to pivot quickly to use that data and a number of other sources like the census and Moody's and CDC, and really take a look at what was going to happen to the veteran community and the support network for that community based on COVID. And we put that paper out quickly, knowing that with COVID, there was likely to be an outpouring of support for the veteran population. Our goal was to see as much of that support go where it was needed most and to address the most pressing issues, which we identified as being a combination of the mental health factors that I described earlier, the return to social isolation, the unemployment issue, financial distress, and a related issue of just some large percentage of nonprofits that might not weather this storm. The smaller ones, the local ones that operate off of volunteers and small budgets, many veterans around the country rely on those organizations for some level of support or care. It may not just be mental health care. It may be food security. It may be emergency financial assistance, number of things. And when you see the impact COVID was going to have not only on employment, but on the viability of some of those organizations, we wanted to get that information out as quickly as we could so that policymakers could use it, other funders could use it, and so that we could in turn move quickly, hold ourselves accountable. We also instituted an expedited grant cycle, so where we opened up for new grants immediately on the heels of this paper. In 2 weeks, we had over 400 applications. So it's clearly there. We wanted to do our best to support it. We've actually got another paper coming out next week that talks about this network and its configuration. So I encourage you to take a look at that as well. And if I missed anything there that you had in mind, Jacob, let me know. But those are some of the highlights of what we were working on.
No, that's great. That's great. And so we're at time, but I do want to say like one plug thing for both what Kacie and Marshall are doing, right, is that it takes collaboration to sort of figure this out. I have the utmost faith that we have some amazing and smart and innovative people in this field. And I think that although it's really challenging to be patient. I think COVID-19 has proven more than anything that mental health in America is so critical. So I am really, really hopeful that when we get through all of this in like 8, 12 months, whatever it may look like, that people are gonna come out the other side and really say like, interesting, mental health is an important thing. And for us, like we're talking about at NBP, is when I'm having conversations with people in our network, it was really challenging for them to understand what social isolation was. And now they get it. And I don't even need to have a conversation. It's like, remember that time that we all had to do this thing, right? And that's been such a breakthrough in conversations with us that I'm sure that Marshall and Kacie are also having, because that stigma is lifted. And although going through a pandemic, I didn't really see that as the way to break that stigma, but the silver lining around some of that stuff is the opportunity to be able to educate people on how important this is. And so thanks so much, Kacie and Marshall, for taking the time with us today. We really appreciate it. For anyone else who wants to check out Kacie's work, she put it in the chat at bushcenter.org/WWA. And then obviously you can find the Bob Woodruff Foundation online and the amazing work they do and the people they fund. Thank you, Kacie and Marshall, for your time. And thanks everyone else for joining us today. Have a great, fantastic rest of your week and weekend.